Thank you very much for inviting me to this meeting and giving me the opportunity to give you an update on radiotherapy for cholangiocarcinoma. Where are we now? I'm Maria Hawkins. I'm a consultant clinical oncologist at University College London Hospital, and I specialize in treatment of hepatobiliary malignancies. Today I will cover 4 key aspects related to radiotherapy. Where are we with the radiotherapy technology now? Do we know if cholangiocarcinoma is sensitive to radiation? Does local radiation enhance survival? And what is the current evidence for radiation use in this setting? So in the last decade, there have been multiple technological advances in radiation therapy, which have helped greatly to improve outcomes in cholangiocarcinoma and other upper gastrointestinal cancers. We use stereotactic ablative radiotherapy, which is a very focused way of giving high doses of radiation precisely. We have multimodality imaging, such as MRI and PET, to help us better target the tumor. And we personalize the radiation to the tumor normal tissue motion. And we started using artificial intelligence technique to improve the radiotherapy planning. And at the bottom of the screen, you see cholangiocarcinoma stereotactic ablative radiotherapy plan. And here you can see the response at 6 months later. The other 2 aspects to help us deliver better radiation are particle therapies. And in UK, we are very fortunate. We have 2 NHS England facilities, one in Manchester and one at UCLH to deliver protons. You can see on the left panels either protons of carbon ions spare the liver, the normal tissue, which is in gray, and on the right panel, the photons on the X-rays give more radiation dose to the normal tissue. The blue is the washout of radiation dose. And it's clear that particle therapies can provide significant benefits in terms of normal tissue sparing for intrahepatic malignancies. Most historical experience with radiotherapy is with fractionated radiotherapy. This is the radiotherapy that's given daily for at least 25 to 30 fractions over 5 to 6 weeks, and often is used with concurrent with brachytherapy. We know that if there is no stent in situ, very ablative radiotherapy may precipitate biliary obstruction and stricture of the biliary tract. And currently, we risk stratify the way we treat patients, so as such that the peripheral tumors would be better suited for ablative radiotherapy as SBRT on the slide, while the extrahepatic tumor are better suited for standard or moderate hypofractionation. Do we know if cholangiocarcinoma is sensitive to radiation? It's difficult to know because we don't have any level 1 evidence, and analogies with pancreatic cancer should not be made. And you can see I've crossed it off here. And one of the challenge we have with this tumor, because it's so rare, we lack robust prospective data. And the data we have is either limited to single institution retrospective reviews, is population-based data sets, so national data sets, And the challenge with this data is that there's a heterogeneity of patients. Patients are mixed with different diseases, such as hilar or distal cholangiocarcinoma and gallbladder. And we all now know that these diseases have different biology. In terms of evidence from the lab about sensitivity to radiation, we know that a KRAS mutation can predict for radiation resistance in multiple clinical models. And here it's an example of a colorectal colon cancer line, where if KRAS mutation was present, there was less response to radiation. And this is what I've seen when I've treated with stereotactic ablative radiotherapy colorectal cancer with liver metastases. The patients who had KRAS mutation had more in-field relapse than the patients who had the KRAS wild types. And of course, the survival was worse to these patients. So we've shown that in other tumor types, KRAS mutation predict for radiation resistance. However, we know that in cholangiocarcinoma, the KRAS mutation is not as high as in other tumors. And specifically for intrahepatic cholangiocarcinoma, the KRAS mutation is less than 25%. Regardless of the genetic mutations harbored by the tumor, when radiation is used, ideally we should sequence radiation post-systemic treatments, as systemic treatments are established in these cancers. Do we know if local radiation treatment enhances survival? So this is population-based data I alluded to earlier. This is data from the United States, from their CCA database. And really, they looked at patients with cholangiocarcinoma across nearly sort of a decade. And you can see on the right-hand side that the patients treated between 2004 and 2009, there were 2,300 patients, of which 24% had surgery and 300 had radiotherapy. And on the left-hand side of the graph, you can see we've got more recent patients between 2010 and 2013. Again, more than 2,000 patients, out of which about 300 received radiotherapy and similar numbers of patients were operated on. But what's interesting to note that after 1 or 2 years, there is this tail of about 30% survival probability in patients who received radiation. And this is appears to be higher in the more recent patients compared to patients from the early 2000s. And perhaps that this is a reflection of the improvements in radiation technology I've discussed earlier, but also gives an indication that there is a group of patients who perhaps would benefit from local treatment with radiation. The other piece of data we have is in patients with metastatic intrahepatic cholangiocarcinoma. So this is data from the National Cancer Database, again, a US database, where they looked at patients over a decade who receive liver-directed local therapies, so surgery or radiotherapy, a more than 45 grade, this is the curative range, in patients with metastatic cholangiocarcinoma. And what's interesting to note is that the survival rate, even though the number of the patients are quite small, it appears that chemotherapy with liver-directed local treatment, whether surgery or radiotherapy, appears to improve overall survival. And then at the bottom of the graph, you've got survival curve for patients who are propensity score match, which means that patient's characteristics and tumor characteristics were matched. Again, we see perhaps that there will be some benefit of adding radiotherapy as a local treatment to this group of patients. So what evidence we have that radiotherapy benefits? The other aspect when we consider using radiotherapy is the pattern of failure. And we know that some cholangiocarcinoma locations, such as extrahepatic cholangiocarcinoma, appears to have a dominant local regional pattern of failure. And unlike pancreatic cancer, it appears to have a better survival. The other rationale to use local treatment is to maintain local tumor control with the aim to preserve the biliary function and quality of life. And this might be something we could consider in our patients, even though we not always have a survival benefit, because quality of life with preserved biliary function is something very important to be able to receive systemic treatment or plan activities. When we did a review of patients with cholangiocarcinoma treated with stereotactic ablative radiotherapy, so this is from 2000 onwards, you can see the number of patients is very small. So these are published series. The largest is 58, and the follow-up for these patients varies, and in its maximum 5 years. But really, this highlights the challenge of understanding which are the patients who benefit. And here you can see half of the patients perhaps either intrahepatic or extrahepatic, depending on which series you're looking at. What's important to know that the local control at 1 year in this series, it's between 78 to 100% if patients receive equivalent of more than 80 gray. And the toxicity varies between 6 to 10% related to biliary stenosis and duodenal ulceration. So these are the key aspects to consider when you look at published data. Again, the 1 and 2 year overall survival of the paper I just showed you highlights that about 50% of the patients would be alive at 1 year, with the numbers becoming smaller in the 2 years. The other big series of intrahepatic cholangiocarcinoma comes from MD Anderson in Boston, and they report 79 patients with inoperable tumors, out of which more than half have positive nodes who receive standard or modestly hypofractionated radiotherapy with a dose of about 80 gray. They had a follow-up of more than 2 years for all patients. Now, what's important in this patient, it shows that the higher the dose of radiation could be given, the local control increases. And the patients who receive a higher dose of radiation, more than 80 gray, had a 3-year local control of nearly 80%. And the median survival in this cohort was 30 months. And again, in patients who receive a higher dose of radiation, the 3-year overall survival is about 70%. The median overall survival has not reached in the patients that receive a high dose. And this highlights the importance of giving an ablative dose of radiations for these patients. And the other evidence that comes from US related to particle radiation, it's a phase 2 prospective study of high-dose hypofractionated proton therapy, which included a mixed population of cholangiocarcinoma and hepatocellular carcinoma. But really, 37 patients in this group were cholangiocarcinoma, which are the yellow colored bars on the graph. And really, it shows that with protons, with doses of equivalent 80 gray, the local control at 2 years was 94%, and the overall survival in these patients at 2 years was 46%. So particle therapy appears to give an excellent local control. We know that after resection, more than 50% of patients have local regional recurrence, and having a positive margin. This is the BILCAP study. We see that having a positive margin after surgery outcomes in terms of local failure are high. The only prospective data about adjuvant radiotherapy after surgery is the SWOG study, which is a single-arm phase 2 US study, which included extrahepatic cholangiocarcinoma and gallbladder cancers, which were resected and had positive nodes or positive margin. And really, this trial met the primary endpoint. And it also showed that radiation appears to be of benefit in positive margin patients. But what we don't know is if this would have been a randomized study, we would have identified which other patients might benefit from radiation. So this is the current ongoing trials for cholangiocarcinoma. There is perioperative chemoradiation prior to transplant, ongoing in France, the TransField study, which is recruiting really well. Pan-European, we've got Actica-RT in the post-operative setting, and there are 3 studies in the locally advanced setting. And I'm just going to highlight them further. So the overall overview of Actica-1 is planning to recruit 108 patients who all have positive margin after surgery, and they are randomized to receive radiotherapy or not, looking to increase the local control at 2 years from 20% to 45%. This trial is open and recruiting in Germany and Australia. ABC07 looks at the addition of stereotactic body radiotherapy to systemic chemotherapy in locally advanced biliary tract cancers. We are looking at the progression-free survival improvement from 45% to 62% in 9 months from randomization. And so far, more than 61 patients have been recruited. So in summary, the role of radiotherapy is increasing but unproven. We need to support acquiring high-level evidence of radiotherapy and recruit to trials. We know that a high percentage of cholangiocarcinoma are KRAS wild type, suggesting perhaps that understanding biology will help us select patients who are more likely to respond to radiation. And there is data that high-dose radiation can control intrahepatic cholangiocarcinoma. We need to identify molecular signature and biomarker where a rationale of combining radiation and drugs could be beneficial. We need to do work to understand which low metastatic potential patients would benefit from ablative radiotherapy treatment, and how to combine and sequence radiotherapy with the new biological targeted treatments that are currently used. Thank you. I'm looking forward for the discussion in the live session.